So I'm going to start with just a fast overview of my story so that you have some idea where these data pieces fit in. So I was a college student, I got sick at 21, and I ended up with a rare disease and spending the next 11 years homebound and bedbound. I saw doctor after doctor and they had no answers for me. They couldn't tell me what was wrong or what would help. I could walk about 50 feet and I could stand for about the length of a commercial break on a TV show. And if I overdid or even ate the wrong kind of meal, my heart would race, the room would spin, I'd have terrible muscle cramps. Sometimes you could put a piece of loose leaf paper on my chest and watch it flutter because my heart was beating that hard. I could eat a peanut butter and jelly sandwich and have a glass of milk and have a heart rate of 140 for 2 hours even while laying down. So my life was a disaster. I spent 22 hours a day in a hospital bed in my living room, and no one was offering me answers, hope, feedback, or even leadership. So I decided to change things up and to take the lead. And I decided I would tackle my problem like a scientist. I would bring a different skill set to this. I would still partner with the doctors, but where we struggled to find answers, I was going to take the lead. And so that's what I did. I was able to figure out what was wrong. I have an autonomic nervous system problem. And I was able to develop novel treatments to keep the condition at bay as best I could. And eventually I developed the surgery to fix me. We adapted an animal model of surgery, a dog surgery from the 1920s, into a modern human surgery. And then I bet my life on the operating table, and it paid off. I also developed new uses for 5 existing prescription drugs. And in all, in the 14 years I was doing this stuff, I worked with 35 senior faculty at 28 different places. So where does the data stuff fit into that story? Well, having my own data let me succeed. So one of the most important things is if you're going to get a surgery, you need something to operate on. I ended up getting a scan that showed the problem. And it took us a year to even pick what scan because the condition we were looking for was so rare. And so I get this scan and my internist calls me and says, "I'm sorry, we didn't find anything. The results were negative." But good processes lead to good results. So just as we'd done with previous negative scans, I got the report. And I also sent the images to my autonomic expert at University of Alabama, Birmingham. So I get the report, and the report says there's increased uptake in the adrenals, may be consistent with adrenal medullary hyperplasia. Well, that was the problem we were looking for. And it turned out my internist thought that they were hedging like economists. And he said no. And so now I'm in this spot where we've gone from no to maybe. Then Dr. Coughlin gets the images, and I get him on the phone, and he says, basically, eureka, we've found it. So what the heck happened with the report? Now that I had the report, I called Washington University Radiology. And what they said was, your condition is so rare that we've never seen it, so we are not sure if we're seeing it now. That's why it's maybe. And even though Dr. Coughlin is an expert, people are doubting his ability. He says he's seen it, and they're kind of like, So I had to see the images myself. I taught myself how to read them. They weren't that difficult, but I did get them. So I got JPEGs of my own images back in 2006, and I sent them to a friend at the NIH. And he wrote back, increased uptake in the adrenals, this is an abnormal scan. Then I sent them to the director of clinical research at Vanderbilt, who ran the world's largest interdisciplinary center on autonomic dysfunction. And he agreed as well. Increased uptake, the scan is abnormal. Then I sent them to my friend who does the screening for PHIOs, for adrenaline tumors at the Cleveland Clinic, and to an endocrine surgeon at UChicago. Pretty soon we had all of those people agreeing the scan is abnormal, showing a problem. And now they were confirming what WashU said and what UAB said. And all of that information is exactly opposite of what my internist brought to me. And I wouldn't have been able to arrange any of that without my data. And frankly, my internist was a wonderful guy, but he didn't know the PHIO screener at the Cleveland Clinic. So he wouldn't necessarily have been able to arrange this either. So that was great. Now we could all agree my adrenals were abnormal. What do we do? Surgery would have been the next step, but since it was both adrenal glands and there was no encapsulated tumor to remove, if we pulled the whole glands, we'd give me a new disease. But at first we couldn't even agree that surgery would be a good idea. So this is what I did. I call this the Brady Bunch slide. I took my images, which are number 11 and 12, and then I took 10 images from peer-reviewed journal articles of the same scan that had led to successful adrenal surgeries. And I put the onus back on the doctors. Instead of inaction, I basically said, if these 10 scans led to successful surgeries, tell me how 11 and 12 are different. Tell me how mine don't appear the same. And that was compelling. Now it was time to do the surgery. The first one's a lot of help. The second one, my recovery is complicated. And now we don't know. Am I suffering from the disease that was created by the surgery by taking so much tissue? Or is it still my old autonomic problem and it's just a little more complicated than we thought? So there's 2 medicines that I was on, and one was for the steroid part, the outside, and one was for my old problem. So I created my own data. I graphed my medication doses for the 100 days after the surgery. And then I added those blue arrows to represent hospitalizations for the periods of worst health. And you could see in the outside of the adrenal gland part, in the steroid part, there was no correlation. But when you went to the adrenaline drug part, to the beta blocker, I cut the drug, I end up in the hospital. After my second hospitalization, it dawned on me what was likely going on. We started increasing the drug, and the hospitalizations stopped. So we had no way testing to determine whether my symptoms were caused by the surgery, taking healthy tissue, or by my old condition still just not being fully put to bed, until I made these graphs and shared them with my team. So that's what we had to do. Back when I was in the hospital bed and I was selling this surgery that I invented in my living room, and I was connecting with the medical team about doing this thing that they'd done on dogs, I pulled all the information together, and it was 363 pages. And I had this vision of me mailing it to Chicago and it landing on this desk and this doctor heaving a deep sigh and never looking at it. So I turned all of my information into one interactive PDF. It had an introduction that walked you through it. It had excerpts from the journals. It had the reports and letters and emails from specialists all over the world. It had the radiology reports and the images embedded. And then it had the full text of the articles. Because I've met doctors, and what they'll say is, if you show them an excerpt, they'll say, I need to see the whole article. And if you show them the whole article, they're going to say, I don't have time to read the whole article. So I gave them both. I built this digital document with links in it. If they wanted to find the surgery that had been done on a monkey, they just had to type the word monkey. There were links in it you could fly around in a website. Now I could get a doctor on the phone for 10 or 15 minutes, and we could get real progress. And if this was paper, it couldn't have happened. So I'm up here telling you this because the next time somebody tells you, I don't even know what a patient would do if they had their own data, that's right, you don't. So the one thing I'm doing now, in addition to giving speeches and talking about innovation and building workshops, is I'm setting up a business as a personal medical consultant. I'm going to take the skills that I developed building these teams and building innovative communication documents and turning piles of records into something usable, and I'm going to help a very small number of rare disease and complex condition patients who find themselves stuck in the system. If you know somebody, I can take probably 5 or fewer patients because I'll be spending hundreds of hours, whereas the medical system simply can't. I don't want to invent new treatments. I don't treat people, but I can support both the doctors and the patients. And when the system gets stuck, I can help people find a way around it. So if you know someone who might be a client or a nonprofit or something that would be particularly interested in talking about this, I'd love to hear from it. Thank you.